Okay, we'll go ahead and get started, and I'll just let people in as they join. Welcome, everybody, to Family First Wednesdays. Family First Wednesdays is a monthly webinar for family peer supporters and families raising children with special health care needs and/or behavioral health challenges. I am your host, Beth Ayers. I am a mom to two adult children with behavioral health challenges, and I'm the executive director of Family Peers for Hope. Family Peers for Hope is a new 501c3 family-run org with a mission to lead the development and expansion of family peer support in Montana, providing hope, empowering families, building connections, and inspiring change. Thank everybody for being here today. Our presenter is Josie Gibbs. She is the clinical director at Little Legends Therapy, which is an OT therapy clinic here in the Billings area. Little Legends' mission is to provide holistic, non-traditional, and comprehensive occupational therapy services to children 0 to 21 and their families. Little Legends wants to create a safe therapy environment for children to hone their strengths and build on their weakness to reach their maximum potential, facilitating success in their daily missions. So I'm excited to have Josie here with us to tell us more about Little Legends. Thanks for being here, Josie.
Absolutely. All right, let me go ahead and share. And hopefully that is popping up for everybody.
Yep, looks good.
Okay. So, just a little bit about myself. I am a registered and licensed occupational therapist in the state of Montana. And like she mentioned, I am the clinical director here at Little Legends Therapy. And I am also the student coordinator. So I am in charge of kind of bringing in our fieldwork students and helping with the education of OT students, which is something I really enjoy. And I have specialty certifications for working with clients with autism, as well as the CPR-CS is a reflex certification, which is kind of a complex neurological thing. So it sounds more complex than it is, but I just have a lot of letters, but just a few extra things. All of my OT experience is with pediatrics, but OT does span the lifespan, which I will talk about briefly. I have worked with adults in other medical settings. I've had a few different jobs throughout my life. I worked as a CNA, as an EMT, so I know that working with adults is not what I want to do. And right now, my caseload is mainly 4 to 12-year-olds. But we do see a variety of ages here at the clinic. We just kind of all have our own preference of ages. Teenagers kind of scare me, to be honest, so I let the other OTs work with the teenagers. So to kind of jump into the basics of OT, I don't know if everyone is kind of familiar with occupational therapy or not. We get the running joke of, are you going to find me a job? Is kind of what the running joke is, like I said. But occupation is referring to whatever the daily tasks, hobbies, and self-care is for the individual. And for kids, that means playing, school, self-care. So that could be bathing, completing chores in the household, and then the social aspect as well. So if they're making friends, if they are interacting with their parents and their siblings, kind of things like that. Um, OT services are available for the lifespan, which is an interesting thing when it comes to our education. We do have to train to work from birth until kind of until death. And so it is a very comprehensive education. And so even when we know if we're going to be working with peds or adults, we have to know all of it, especially for when it comes to the testing component. So it is a lot to learn, and it is pretty beneficial though to when we are working with the kids or working with the adults, kind of thinking backwards or thinking forwards of how is their performance now going to impact later in life, or the opposite of how are they performing now as adults? How did it look like when they were children? So that's kind of an interesting component of our job. We do work pretty closely with other professionals, physical therapy, speech therapy, social work, um, counseling, any of the school services, um, psychology in general, or psychiatry services. Our basic setup is that we see kids weekly, and on average, we will see kids for a range of 6 months to 2 years. We have the outliers, of course, for we can see kids for 3 months, or we have some kids that will stay on for several years up to the majority of um, their adolescence. But overall, the main function of OT, or the main focus of OT, is going to be function, participation, and independence in whatever they value and what is important to them. And then our practice, we have a big focus on sensory motor, behavioral regulation, and then attention and academic challenges. So I will kind of jump into those a little bit more. Um, People often ask who's going to benefit from attending OT services. So we get quite a range of referrals. And the general process is going to be you can either like call into a clinic, or we just get a referral from a pediatrician or a psychiatrist. It's kind of the same process of getting a prescription to a pharmacy. We have to have something official from a doctor, but um, people are able to call in. We just have to have that official before we do an evaluation, but we're able to answer questions before that formally starts. But we do have kind of the generic diagnoses of ADHD. ADD is kind of being phased out, is the trend that we're seeing, and it's now just ADD. And then the subtypes of that, we have sensory processing disorder, autism spectrum disorder. We are seeing the oppositional defiant disorder. That one we don't get super often, but we do see every now and again. We see quite a bit of anxiety and depression, and other mental health disorders. We don't see a lot of physical based diagnoses such as cerebral palsy at our clinic. They are often referred to a clinic that has a multidisciplinary team that has speech and physical therapy providers all in one location. So scheduling is a little bit easier for the family, but that is something that occupational therapists would be involved in treatment. Um, but dyspraxia, or um, just motor coordination in general, is something that an OT would definitely want to be involved in. And then just a general developmental delay is something that's kind of diagnosed, that is very broad, and we are often given that in a referral with no other information. And um, so we don't know if that's fine motor, gross motor, communication. We have no idea until the kid comes in what that delay is going to be. And then some of the kind of informal diagnoses are going to be just fine motor challenges. If the kid has eating challenges, that might be redirected to a speech therapist if it's more of an anatomy concern versus picky eating. If the kid is just overly clumsy, if they're running into everything and just kind of crashing all the time, that's something that would bring a kid into OT. More and more, especially I would say within the last 10, 15 years, uh, 75% of our kids at the moment, emotional regulation, attention difficulties, and social concerns are the majority of what our kids are in OT for right now, especially at our clinic. Um, and then sometimes with the older kids and the teenagers, it's a lot of that self-care and hygiene. And again, kind of those social concerns of just inappropriate conversations or like not knowing how to sustain friendships, just those kind of things. And then just academic challenges, not necessarily um, not the kids that are getting C's and B's, but the ones that are really far behind and just don't seem to care, or they have no drive. So we work a lot on the initiation process. Um, Something that is important for our clinic is the bottom up approach. So this is um, something in occupational therapy that is becoming a little bit more prevalent and important is starting from the bottom and working our way up. And it is the opposite of what the American medical model is. So we're not treating symptoms, we are treating underlying problems. So if we're looking at the pyramid, the central nervous system is not necessarily something that we are addressing. That would be a neurologist if that is truly the problem. I'm not qualified to do that. But if at the top we are failing classes and we are acting out and we're not able to complete anything at home that our parents are asking us to do, it's not necessarily because we are a bad kid. It's not because we are dumb. It's not because we need to be written off and we're a problem child. It's because we are functioning in that blue zone. Our sensory system is completely out of whack. We can't even process things auditorily, or we're in the green zone and we have motor reflexes that are firing when they're not supposed to. And the left side of our brain and the right side of our brain are not talking to each other. And so that's kind of our job as the OT, is to go in and figure out what section of the triangle that they are functioning in and addressing those skills and working on those and working from the bottom up. And so kind of the sensory motor component is where we start with everyone. So we evaluate where they are functioning in their sensory systems. And that's something that I think I've told every single parent that I've evaluated for the last several years is the auditory system in any child is the last thing to develop in a child. Telling them directions is not helpful. You have to show them directions, you have to help them with directions, give them a picture, do it with them, act it out, whatever. Just telling them is goes in one ear, out the other. I don't even think it goes in one ear. It's not, it's not processing. It's why we don't have sit down lectures until a student is in college, because that's not how children are learning. Um, and so that's how things are adapted. And so, like, it's a system, is long story short, is what I'm trying to say. Um, and so if we're looking at those list of diagnoses that we went back to and what they're getting referred for, if it's attention, if it's ADHD, is it truly an attention problem, or is it a sensory problem? Is it a motor coordination problem paired with an attention problem, paired with a reflex problem, paired with something else? And so that's where OT comes in, and that's where our knowledge is really helpful for parents and teachers, and kind of that collaborative process to pair everything together, um, and just kind of addressing and identifying those underlying problems before that kid is written off, and failing, and just parents are fed up with behavior and whatever it may be. Um, so, yep, we look at the dysfunction and actually find the root cause. Um, let's see. And 9 times out of 10, most of the kids that we see are kind of functioning in the green or blue area, and the red and yellow is kind of should be later middle school to high school function, um, if development is on track. And even then, I would say with the way things are trending, that's pretty hard for a lot of kids to be on good track for that. This is a big long list of things that OT can address, starting with the fine motor and visual motor. I feel like this is kind of the stereotypical stuff that people think of for OT. A lot of the fine motor skills and visual motor skills, um, super important in general development. It's a lot of the skills that kids are practicing on a daily basis anyways. So we use these in functional tasks as we go along. So we don't necessarily sit down and practice buttons. Some clinics might, when older adults are recovering from a stroke, they do. They're going to sit and practice dressing. Um, and if it's a child recovering from an injury and it's or like a hospitalization, and that's kind of the only concern that might be more relevant. But I have yet to really work on just a buttoning or a zipping task. We just kind of incorporate into something a little bit more functional and a little bit more fun, because that's how the kids are motivated to participate with us. So those skills are kind of tied in with board games, or crafts is kind of a big one that we do. And so we're using grasp, we're using scissors, we're using coloring, we're using writing in fun worksheets or crafts, or we're doing puzzles while you're riding around on one of the bikes to find the puzzle pieces or following directions. And so you have to have a working memory component. You're following the directions, so you're processing the auditory component, kind of things like that. So it's multitasking. So we're pairing 10 different skills into one task, and the kid doesn't know that's actually what they're working on. But hand-eye coordination, um, unfortunately, the trends that we're seeing, um, I don't know how many kids are outside just playing catch with their parents anymore. It's not something that I'm seeing as much as I feel like we used to. I think generationally, playing outside and just kind of doing as much active play is that those trends are going down. And so a little bit of those coordination tasks are diminishing as well. So the climbing, jumping, balancing is going down, as screen time is going up. I'm sure we all could complain about screen time stuff for hours on end, but I won't jump on that boat quite yet. Social skills, we try to manipulate our schedule as much as we can to pair kids. So the therapists are working with kids around the same age or the same skill level so they could interact as much as we can. That doesn't always work based on parent schedules, obviously, but when we can, we try to do some co-treatment so they can interact and play games together. So they can work on empathy, they can work on turn taking, they can work on frustration tolerance when they're losing a game. That's a big one, because a kid can't make me mad if I lose a game. I can act it out, but I don't really care. But another kid might flip a table. That is something that has happened. So, or my kid might flip a table. So, how do we react if someone else is freaking out? Or how do we react if we want to freak out? So, kind of working on those skills. Um, Executive function is kind of the big buzzword right now with what we're working on. So, those forward thinking skills and problem solving. If I do A, what is the result? Or if I do B, what is that result going to be? Planning, both in our brains and physically. Organization, again, in our brains and physically. Time management is a big one, especially with the teens and young adults. Initiation is another one. It's something that I did not predict coming into the OT field, how many kids can't decide what they want to do. Um, I will show pictures of our clinic in a few slides, and there's really cool stuff. And we have a lot of kids that walk in and they just like stare. And I'm like, you have 100 things that you could choose from, and they just have no idea. And so just working on the initiation and coming up with an idea is really, really hard. And so working on that skill is something that I think a lot of people didn't anticipate being such a deficit for kids. And so when it comes to school, teachers get really frustrated of like, I gave you your worksheet, I gave you your directions. Why are you not following through? And it's because they don't have that initiation skill. And so just practicing things like that. Self-regulation, again, that's the big one right now. So impulse control in any situation. Um, to some extent, it is normal for kids not to have impulse control. That is a stage, that is a milestone for kids to not have that to some extent and not to go through a developmentally appropriate stage of not having that. Um, and that's kind of a conversation that you can have with an OT of when it's appropriate or not, and when you need professional help of kind of teaching a kid to have that mental stop sign of when we need it before we're having behaviors. Um, Emotional recognition. There's a lot of kids that don't know the difference between I'm frustrated, I'm sad, I'm overwhelmed, I'm angry. It's just freaking out in any direction. They don't really know which direction it is. General coping skills, behavioral control, kind of going along with the impulse control or emotional regulation. Again, that frustration tolerance, whether that's in the social setting or frustration tolerance with their own actions. Transitioning is a big one as well with um, between tasks. That one is something we get a lot with toddlers and young adolescents. Transitioning between tasks is something that we get complaints a lot with parents, especially in daily routines or changes in routines. So we have a lot of pretty simple suggestions that we give for parents with those ones. But big behaviors when it comes to transitions, that's pretty normal. Last little section here, we have ADLs, which is activities of daily living. So kind of those self-care tasks. So dressing, bathing, brushing your hair, brushing your teeth, general hygiene, especially when we get into the puberty stage. Are we taking care of ourselves? Are we aware that we are going through puberty? Are we aware of body odor, and how others are perceiving us? Kind of things like that. And then just general sensory processing. I think that's kind of a big buzzword of what OT is associated with as well. So just tactile aversions, hypersensitivity, especially with sound, is a big one that we work with, picky eating, and then being overly rough. So these are the kids that are crashing into everything. They're crashing into people. They're the kids that are walking into the corners of couches. They're falling over all the time. They're jumping off the top deck of the playground and just have no sense of safety. So that would be kind of OT's realm as well. For our sessions, I can kind of go over just what it would look like for us. We have in general, we see kids for an hour every week. So we just greet the kid and typically it's their parent. If parents are working, sometimes it's a grandparent, aunt or uncle, older sibling, friend of the family, whomever. Um, they typically give us kind of an update on the week, how school's been, how things went over the weekend, whatever, or parents will text me. He threw a chair at his teacher over the weekend, or he actually played a game with his brother without getting in a fight, or he got an A on his spelling test, whatever it may be. Just kind of getting a little debrief from the parent is how we start. We come in and we make a plan with the child. Um, some of the older kids don't, but if, especially with the kids that have a hard time coming up with plans, we write it all down. And that helps a lot with the kids that have difficulty transitioning or having a mental plan. And we, for the most part, choose 4 tasks for the day, and we alternate it between something I want and something they want. And that way it can be kind of motivating for them. So we do something that's actual work, and that's what I choose. And then they're motivated to get to choose something fun that they choose. And within reason, um, if we try to steer it so they're not choosing the exact same thing every time, and sometimes it becomes a negotiation or compromise, or um, we have to navigate that carefully with some clients. Um, Most of the time, the first task that we use is regulation, um, especially for kids if they are coming from school or after school and they need a lot of movement or something tactile. We call it messy hands. So they need something to calm and regulate the body. The second task is a little bit more cognitively challenging. So if we're doing something that takes a little bit more thinking power or something that's a little bit more challenging in the social domain. The third task is going to be a little bit more challenging in the coordination domain. So if it's fine motor, visual motor, or gross motor, depending on what their challenges are. And then the fourth task is usually something fun, but still appropriately challenging. So a lot of kids will choose a board game or like we have like puzzle type games like brain teaser games or Legos or a social story, things like that. If it is a kid that is pretty sensory motor seeking, we can also do a secondary regulating task before we send them home to parents if they're super um, amped up. We don't want to send them home to parents like super, super heightened. Parents would probably not appreciate that. So they can do the swing, they can do a tactile task, or we often read some social stories. I have I think a video of like our sensory room, and it's a very calming room that we have where we do the books. Um, so this is just a few pictures of what our space looks like. So we are in like a big office building, but we do have our ceiling modified, so we have several swing setups. I think we have like 9 or 10 different swings. This is actually our office manager's daughter on the swing there. And in the background, those are Lycra um, hammocks, and they're stacked to work on some strengthening to climb up. They're actually pretty challenging. I can only climb them because I'm tall enough to reach the top, but it works on some vestibular input and kind of just that body awareness. A lot of kids really hate using it because it is so disorienting to the body, which means it's really good work for them. And if they get uncomfortable using it, that's when you know that that's actually when they need to be using it. But once they get used to how uncomfortable it makes their body, a lot of kids really crave the feeling. Um, and then we just have some general other climbing equipment off to the left there. And then the trampoline on the right, that is me and some clients and a student of mine doing some Yogorilla cards. And so just kind of working on some motor coordination, and we were doing it with a peer because one of the clients did not want to do it at all, and the other one thought it was really fun. So just kind of using one peer to motivate the other and working on coordination. And sometimes things like that, it's one side of the body can do a lot of the tasks that we're asking them to do, and the other side cannot. And whether that's a neurological reason, and just kind of practicing those skills. We do a lot of obstacle courses. We have a very large open space, which is nice. And then the girl on the right is, um, we had a task about, it's like you roll a dice cube thing and you have to like copy the shapes. So it's like a visual task. And if you can copy different shapes, and then she's laying on the wedge because she has poor postural control and she's not able to sustain her posture sitting at a table. And so we're adapting that by supporting her trunk and not putting so much, like, I don't want to say pressure because that's not quite the word I'm looking for, but not putting so much demand on her shoulder strength to move her arm because she could do the task, but her body doesn't allow her to do it successfully because she can't actually sit at the desk. So we modify it by having her lay on the wedge so she's supported and is able to do it successfully. I have some just quick videos. So we do some different things on the trampoline. So just lots of proprioceptive input is just the pressure on your body, jumping on the trampoline. That was a sword fight with pool noodles, kind of working on the social component of, are we going to absolutely destroy the other kid with the pool noodle? Can we play appropriately? And can we interact appropriately or not? And if we're not, and the pool noodles get taken away, or if we have to transition out, how do we react to that? The second video, this is the sensory room I was talking about. So lots of visual input, or we can turn the lights off. And then that was super quick, but there's a tent in there. And it's kind of away from the louder environment. So we do lots of stories in there, but I also eat my lunch in there quite a bit because I just like the lights, but let's see what's next. Some areas that we focus on specifically in our clinic is the sense of interoception. This is actually, there are not 5 senses in the body, there are more. Interoception is one that gets overlooked and missed. It is the internal body awareness and the sense of body signals. So we go through a program with every client that comes through after a certain age. And we talk about body signals. So very few kids, when they come to our clinic, have a sense of what their body is feeling in relation to emotion. So kind of going back to that emotional recognition of knowing if I'm frustrated or mad, or whether I'm sad or overwhelmed, we want them to recognize, okay, when I'm starting to get frustrated, I know that my heart is starting to beat faster. My face is starting to get hot. Or when I'm starting to get overwhelmed, my ears start to get a little sensitive. My body starts to get a little wiggly. My brain is distracted. So kind of those kind of warning factors leading into different emotions. And we go through every body system and talk about body signals. We then relate it to the emotions, and then we talk about coping skills. So a lot of schools use zones of regulation, which is a great program. I have nothing against zones of regulation. I think it's a great visual to have and for kids to start recognizing emotions and choose coping skills. but they miss a huge factor of talking about why they are feeling emotions and how they know that they're feeling emotions. So this is kind of the first step. And if you teach these skills, then you can jump into the zones of regulation. So I wish this was something that was taught a little bit more because there's very few kids that have this skill. And we have a lot of parents model this. Um, that's like the first step. Day one on a first session, we teach parents. I'm like, okay, we talked about the hands today. I want you to talk about when you're feeling frustrated, your hands get a little clenched, and you start talking about that when you are frustrated and start modeling those behaviors with your kids. We are providers of something called the Safe and Sound Protocol through the Integrated Listening Systems program. I'm not sure if any of you guys are familiar with that, but it's a music based therapeutic approach. Um, it's um, kind of filtered music. It's a 5-hour program. Um, I mostly compare the music. It sounds like it's coming out of a gramophone, and it's been researched to reduce symptoms in depression and anxiety, PTSD, some neurodevelopmental differences, any trauma history, some sleep differences, kind of a long list of different things. And so we've seen some benefits with just a lot of, mostly for us, the auditory hypersensitivity. So that's something that we use with a lot of different kids. And then the last one is X, which is something that we've all completed a training for as well. And it's a coordination exercise program that has a lot of different patterned and rhythmic ball and beanbag passing um, exercises, and I'll show a really short clip. They're all completed on a balance board and they all focus on crossing midline. They're all very specific, and the title stands for Balance Auditory Visual Exercises. And it was created by a man. I think he was a teacher. And it's been very beneficial in just working on kind of working with a partner and hand-eye coordination, but also just like auditory processing. And you have to match the rhythm, and it's very regulating. Um, and it's just been pretty cool to see. They're very strict about their program. It's kind of a weird, you guys can like YouTube if you're interested in seeing it, but the kids really like it because you're passing things. They're racquetballs, so they're super bouncy, and you're going crossing different ways and passing multiple balls at the same time. The clip that I have is three of us OTs just kind of bouncing them differently, and it's kind of looped, so it's pretty quick. But um, the training was fun, and even as adults, it's like pretty hard. But you're bouncing things different ways, and Andrew on the right's doing three, and they're all the kids are like, I'm juggling because you're bouncing it on the ground. But most of the time with the kids, we're doing it together as partners. We're almost done here. I have just quick frequently asked questions with OT. So a lot of what we do just kind of looks like play. So a lot of parents come in and they're like, what are you even working on? It looks like you're just playing. Um, quick answer is yes, I am just playing with your kid. No, it's not just play. But that is how you do teach kids skills. That is how I keep them interested in coming back. Um, so that is how a kid is going to learn, and that's how parents are able to engage as well. So if you're having a hard time getting your kid to engage with you, is start teaching them skills, play a board game with them, and see if something's challenging. Keep working on that skill or keep doing that board game. Don't keep playing the same thing over and over again, because when they're good at it, of course they want to keep playing. They're good at it. You have to challenge them. Um, Is OT only for the kids with disabilities? Nope. OT can help support the needs of any child's development. Um, and that can actually be part of the tricky part when it comes to knowing when it's time to discharge any kid, because as kids grow and continue to need assistance and development, how do you know when it's time to say goodbye? Because they're always learning and I can always help. So, but normal learning and needing assistance in learning, when you got to, that's when you need to ask for help. Um, and then when should I be concerned or know if I need to Wow. When should I be concerned or how do I know if we need OT? That would be talking with a pediatrician first or calling your closest OT. Some clinics offer a screening service before a full assessment. So you can often just ask um, the clinic questions. Often they can answer on the phone if it's going to be an OT related problem or redirect you to other fields. The connection between OT and behavioral health, if I haven't covered it already, is our interventions are closely linked as we're working on the executive function component. So, attention, organization, planning, and problem solving. And we're pretty collaborative with the other fields, especially if they are working with neuropsych or psychiatric services. We are strength based, at least here, and other OT should be as well, or at least I would hope that they are. Um, and behavior is coming from somewhere. And if it is because of a deficit, then that's our goal is to address those. And OT, we do use cognitive behavioral therapy. And so um, thinking about your thinking, and that's something we utilize and um, kind of again addressing the underlying issues. And that's something that we value. And then just my last slide here is the most important part for OT is not me. It would be parents and caregivers kind of following through on what we're trying to educate you and your kids on. You will have the biggest impact on the development of your kid and their success. And so I am here as a tool. And so utilize my knowledge, utilize my education and my resources. And I want to empower the parents that I'm working with so they can be successful in interactions with their kid. And consistency and communication is vital. So, 1 hour a week, unfortunately, in the grand scheme of things, isn't going to make the biggest difference in the world, as much as I hope it would. It can make a little bit of an impact, but following through and trying to be consistent is pretty important. And then just being honest with your OT. We are pretty judgment free. It's more important for us to know the background and the truth, and so we can address what's really going on. Perfection is impossible. It's the same for us. My sessions are not perfect. I am not perfect. Sometimes it is a hot mess, and our what we do with the kids is like not anything what I had planned for the day, but we get through it. And if we have fun and it's a safe place for an hour, that's a success for me. So I have some contact information and then we can go through some questions. Anyone is welcome to contact me or clinic if you guys have questions about screenings or just resources in general.
Thanks, Josie. Does anybody have any questions? I had just a quick one. Do you guys do groups or are there groups for OT? Is that a thing?
There are, we typically do not. We have our billing system is all one-on-one. Um, there are a couple. I don't know how to actually answer your question. So, most of the time, group-based OT is for adults. And so what it would be is one OT and a group of adults. And that's typically going to be in group homes, assisted living, or like day facilities. I think there are a couple places that will do it with like early adult or kind of those later teen. Um, I don't know any off the top of my head. Excuse me. It would be something that we would like to add, but we don't have enough teen referrals. Um, we do in the summers do a lot of group activities, but it's still
Mm,
one-on-one treatment. We just do it
gotcha.
as a large group. So
Nice.
not technically group in the sense as it is for insurance and billing purposes, but like looking at us, yes, we are a group. So
Gotcha.
yes and no.
Gotcha. Um, and then this isn't really a question, but when our oldest was experiencing behavioral health challenges, I did not even know what OT was, or it was not something I think that was really, this was, gosh, 13 years ago, thought about in the behavioral health realm. And the more I learned about OT, the more I realized just how helpful and beneficial that would have been for, our child and for us as a family. And so, yeah, I think the um the broad impacts of OT are kind of across the board.
Yeah, it's definitely something that um you don't know it exists, unfortunately, until you kind of stumble into it or need it, I
Hmm.
guess. Like I just happened, my own story is kind of funny. It was like job shadow sign up day at school, and I was sick the day that everyone signed up, and so OT was the last option. It was like the only thing left, and so when I came back, I was like, okay, I guess I'm doing OT. And so I like showed up to the clinic, and I had no idea what it was, and so then I stumbled upon it and then fell in love. So,
Hmm.
um, but before that, had no idea that it existed. And so, we have a lot of families even that just they get the referral and they still don't know really what to expect until they come in. And even calling, we're like, hey, this is Little Legends. We got a referral for OT. Like, are you still needing to schedule? And they're like, well, what do you guys do? And I was like, okay, well,
Hmm.
this is OT. Like, first tell me about your kid. Like we can do so many things. Like I just talked for 45 minutes. Like I don't want to tell you the whole spiel. Like tell me about your kid first. Like what are you seeing or like what did you tell your pediatrician? It's faster for you to tell me what you're seeing than it is for me to list all the things that we could help you with.
Hmm.
So even families that which also is kind of falling on the pediatrician for not saying like why
Right.
I'm referring you to OT for this, but so
Yeah.
I have a question
yeah, of course.
Yeah.
that I'm hoping maybe you can give some guidance on. So we have a complex case and the kiddo was out of state for treatment. The occupational therapist um, basically held everything together
Okay.
till this kiddo could go get treatment. But while they were out of state at treatment, the occupational therapist let us know that the kiddo needs more and that they would not be doing occupational therapy with them when they return.
Okay.
They meant like they need more something
Okay.
because of all the behaviors. And like so now that the kiddo's back at group home, those behaviors they're back again, of course.
Mm-hmm.
Um, we get to go to youth court tomorrow.
Mm.
So, what do you recommend for families like ours, where the occupational therapist said that this kiddo needs more before they could go back into occupational therapy, but yet the occupational therapy was one of the better things that happened, that from the family's perspective happened to the kid.
Um, that's a tough one. We come across that every once in a while when it becomes a safety factor. We've had to remove, luckily not a lot. I would say in the past couple of years, maybe 2 or 3 kids from the schedule due to like aggressive behaviors toward other kids on the schedule. Um, and usually we will redirect them to ABA services if it is appropriate. Um, that's typically what the next step is when it comes to behaviors. Um, but that's not an appropriate service for everyone. So depending on kind of the diagnosis or what you guys are seeing, that would be a potential service that
They
to
were
look
turned
into.
down by ABA
Okay.
services early on. They looked at his case. They
Okay.
turned him down. Of course, that company is no longer here because what state choices. The therapist at the other facility suspected some other stuff. But given the complexity of it, I have a suspicion we'd be turned down again for ABA.
Okay. Yeah.
Mhm.
And sometimes it's just referring to a different OT clinic and seeing if you guys can get services elsewhere.
Mhm.
And or trying to have a conversation with the OT of trying to find out why they're trying to end services, if it's like because of like the behaviors or something the OT is no longer willing to address because of personal concerns or yeah, because that's like my assumption based on what you're saying, but
Oh, well, the case is just complex and the occupational therapist knows that this kiddo was just humoring the occupational therapist and not doing the work. It's a consistent theme.
mm-hmm.
So I don't know if that had anything to do with it.
Yeah, and that's something that we come across quite a bit as well of um we that's a hard decision to make when we know that we could be quite helpful if a kid was motivated and they're not, and parents are frustrated, and other people involved in the case are frustrated, and the kid would benefit, and but they come and they don't do the work, or they're only doing the work because they're motivated by whatever it may be. But in the long run, it's not working.
Do you think another piece to that puzzle could be because of another behavior or mental health issue that doesn't get diagnosed till you're 18?
Potentially.
Okay. Because I was wondering that.
Yeah. Yeah. And some things like they can't bring until adulthood, or just a lot of the mental health stuff is overlooked and missed. And um, I think in Montana, we don't necessarily have the resources and the the uh, the extensive availability of mental health resources that we could in larger states and cities.
Do you guys often, like if you're hearing from families across Montana that maybe aren't here in the Billings area, do you guys do a lot of referrals to other occupational therapy clinics across Montana, depending on like the situation?
Um, we don't really have many coming
Okay.
from not the Billings area. Um, but we because most of our stuff is coming from, I would say the opposite. We have more kind of flocking from the surrounding smaller towns that are coming to come see like the children's clinic from the smaller places. And we do have, I guess we had Dr. King,
Mm.
and Dr. Nicholson and now Laura Facella are the um, developmental pediatricians in this area, at least. I'm not familiar if there's ones kind of on the western side of the state. And so those are the only three in this region that are able to diagnose autism. And so we have a lot of people traveling this direction. So we don't get too many kind of going outward. But we
Sure.
do have, since they have such a long waiting list, we do have quite a few that are going for like neuropsych evaluations for the specialists in Helena. So
Okay.
that occasionally, but not so much for OT purposes, more so
Mhm.
like diagnostic purposes.
Any other questions? All right. Well, Josie, thank you so much for being here and for sharing with us about your clinic, and the contact information. I would assume too, if any of us are wanting to know more or want to talk more in specifics about things, you have your email here in your phone. I'm assuming we can give you a call or send you an email
Yep,
if we have anything else. So again, thank you so much for being here.
it was my pleasure.
Thanks. Next month, we will have the Billings Parks and Rec talking about some kind of their programs and hoping to expand to the other parks and rec places across Montana. So be sure to join us for that. Thank you, everybody, for being here, and we will see you next month.